in the past, and I am a food addiction counselor. Today's topic, how do I manage obesity as a chronic disease? Before we introduce our guests, let me tell you a little bit about Obesity Canada. Obesity Canada is Canada's national registered charity dedicated to improving the lives of Canadians through obesity research, education, and advocacy. Through its work, Obesity Canada educates health professionals, supports researchers, mentors, trainees, students, and works with policymakers to ensure that all Canadians living with obesity receive the same level of prevention and care as Canadians living with other chronic diseases like diabetes or hypertension. Now I'm going to allow each of the speakers to introduce themselves. Let's start with Dr. Megha Podamer. Sorry.
No problem. Thanks, everyone. I'm happy to see a lot of friendly faces. Some people I recognize, some people I don't. My name is Megha Podar. I'm actually an endocrinologist here in Toronto, Ontario. I started my journey in obesity medicine right after my fellowship in about 2015. I did some additional training at McMaster University, where I basically curated a fellowship in bariatric surgery and obesity medicine. And that allowed me to write my BAUSCH certification. So in terms of my current practice, I have a general endocrinology practice where I also run a weight management program with a bariatric educator who helps with the psychological sort of treatment facet of obesity, as well as helping patients with referrals to bariatric surgery and the pharmacotherapy treatment paradigm as well. I also work with Dr. Sean Wharton, which many of you are probably familiar with, in his community weight management program where I run the bariatric surgery program. So we're affiliated with a surgical center in Hamilton, Ontario, and I'm seeing patients both pre and post-op for bariatric surgery. Most recently, I've had the honor of co-authoring the assessment chapter of the Canadian Obesity Guidelines that were just recently published. And we've had a lot of great feedback in terms of the guidelines and a lot of great discussion on the guidelines as well. And so I'm happy to take any of your questions and help sort of chat further on any of those topics that come up today.
Thank you. I'm going to ask Dr. Denise Campbell-Scherer to introduce herself.
Hi, everybody. This is fun. I'm looking at all the pictures and I recognize some people, and I'm excited to be here. I'm Denise Campbell-Scherer. I'm a family physician here in Edmonton, Alberta, and I'm a professor in family medicine here as well. So I'm a researcher, and I've been working in the area of how do we advance care for people living with obesity in primary care for about 8 years now. I had met Arya about 8 or 9 years ago. We started working together on the 5A's team program. And so it's been really interesting for me. One of the things I always reflect on is the big gap in training. So there's been such an enormous explosion of knowledge in this area. And I always like to say, discovered a couple of new organs in the body since I was in med school. One of which is the gut microbiome, and one of which is adipose tissue, which, you know, at the time that I was training, we just thought that that was just a storage medium. We had no idea that it was an endocrine active tissue. We had no idea about gut microbiome. I mean, we had no idea about the genetics of this condition. We didn't realize it was a chronic disease. And so nobody was actually trained. And so I remember the first 12 years I was a family doctor, I had no idea how to help people when they would come into my clinic. And at that time, I didn't have a chance of working in a multidisciplinary team. So it was a really challenging situation. And I think when I look at sort of all the things I've learned the last 10 years or so working in the field, it's completely changed my practice. And I think there's a huge educational piece that has to go along with this. So to help people have the skills and knowledge to be able to be more effective clinically. So I am involved with a group of colleagues from around the world that's quite interested in pushing that forward. And then just recently had the great pleasure of serving on the executive for these new clinical practice guidelines, which I'm really happy to see come to fruition. And I think they're hopefully going to help advance the discussion and push forward on some of these things that need to happen with regards to building awareness and helping with knowledge. Then there's the skills piece. So we run a lot of courses as well for primary care providers around how to actually work this practically into the flow of the day, and how to integrate some of this into the work, which is always really interesting for me. Yeah, so I'm excited to be asked to be here today and to get to meet all of you guys and get to meet Mega, who I've never actually met in person. So I know she was one of the authors on the assessment chapter, and I wrote, that was the lead author on the primary care chapter. But aside from in large meetings, we've never actually gotten to chat. So thanks to Obesity Canada and BAUSCH Health for bringing us together to be able to have a bit of a conversation about how we approach obesity as a chronic disease.
Yeah, if I could, I can throw out the first question. What's the evidence that obesity is a chronic disease?
Yeah, I mean, I can sort of start with some of my thoughts on that question. You know, I think it's such an important question to talk about and to ask, because it allows us to really have a forum like this. It allows something like a national organization like Obesity Canada to actually exist. Once we are aware and are establishing obesity as a chronic disease, it opens the doors, I find, to education, to opportunities in research, to really understanding the disease and looking at the science behind what's sort of going on. But probably more importantly to that, and this is something that I think Denise can probably speak to more, is it really does help to establish and reduce the stigma and the bias that's associated with it. As we know, many of you have probably heard of the ACTION study. And from that study, what we really discovered was that patients really feel sort of alone in terms of their ability and tools to be able to manage this condition. And if the discussion is posed as, you know, this is a disease state, a chronic disease state, this is the underlying pathology that's actually happening in your body and your brain that's fighting against the success of weight reduction and your success in the long term. When we introduce the conversation like that, I find that it really helps to decrease that stigma that patients have about themselves, that they're failing, or that this is an issue that they need to manage on their own. They gain the weight on their own, you know, they need to lose the weight on their own. It's really changing the overall discussion, especially patient facing, when we establish obesity as a chronic disease. And when you think about chronic disease, you know, what are we really saying? What we're essentially saying is that this is a disease state that is causing other consequences to other facets of mental health, mechanical health, metabolic health. And it's not really something that is, for all intents and purposes, curable or going to go away. It's something that we need to offer support and tools for in the long term. And really, you know, helping patients to understand that there are ups and downs to their journey in obesity, giving them the tools to understand that, yes, there may be weight regain. You know, this is what's actually happening in our hormonal pathway, from a metabolic pathway, from a, overall sort of what are the changes that are happening in our body that are making this journey more difficult, and how do we help you give the tools to be more successful in the long run.
You know what, I had a question. How do you even recognize the subtleties of internalized bias? You know, I've been in this field for a really long time, and I still have to check my internal bias. How, as a doctor, can you pick up on those subtleties?
You know, I'll sort of jump in what I tend to. You almost have to open your ears and your eyes to a different part of the conversation. So often, as physicians, we're trying to pick out the symptoms, or, you know, what is the sort of scheme of what's going on in the patient to allow for the diagnosis that we're trying to establish. But when I really think about the conversation, it's really, what is the patient's internal conversation that they're having with themselves in hardship? So, you know, even if you pose a question to sort of say, well, how did you feel at that time when you stepped on the scale and you may have noticed that your weight had gone up, even though you had taken all these behaviors into account and improved all these other aspects of life, but the scale still perhaps went up? You know, what did you tell yourself, or how did you feel in that moment? And I find that that internal dialogue is very eye-opening in terms of how patients feel about themselves, what kind of biases they may have about their previous journey, or perhaps how they're feeling about themselves in the current state.
Yeah. So Denise, what are the barriers that can affect the level of care provided to patients?
Oh, well, I was actually still back on the first question because I actually hadn't had a chance to sort of say anything about that.
For sure.
So, I think, I agree with everything that Mega said, but I think the issue is that, obesity is a chronic disease. It's a complex, chronic, relapsing condition that's characterized by, abnormal adipose tissue, which is impairing function, right? So I think this is actually one of the points about the guidelines that are so important. It's moving the needle quite a bit on accepted definitions. We are not using BMI. It is not a discussion about how big someone is. It's a question about how healthy someone is, right? And are there physical or metabolic issues that are being affected for the person based upon that adiposity? And that really ties in with what we were talking about, the pathophysiology of the disease, which we now understand better, which is that we're having actually a change from healthy adipose tissue to unhealthy adipose tissue, and we're having that tissue be deposited in organs where we don't want it to be deposited, like pancreases and livers and skeletal muscle and other places where we don't want it. So there's actually a pathology happening here. This is not just a label to make it convenient or make it more something that's going to make it more acceptable to be treated or appropriately managed. It is actually a chronic disease. And that is probably the biggest barrier to your question about affecting treatment, is that that's not what a lot of people have internalized. So for a long time, the narrative was it was a matter of self-action, that if you worked harder, if you tried harder, if you did more, oh really, you really think that you're doing so much work? Well, it certainly doesn't look like it, and that kind of external and internal bias and stigma that thought that you could actually judge what somebody was doing based upon how they present phenotypically in the world is probably the single biggest barrier that has to shift. Because if that's the narrative, that you did this to yourself, you caused this yourself, not that you actually are suffering with a very complex chronic disease that we're just beginning to understand, then the internalized bias that comes, as per what you were just speaking of with Mega, is therefore I don't really deserve treatment, because I've done this to myself. So we actually have to have a huge gap of understanding for people to actually recognize that no, this is actually a chronic disease. And while I can control my behaviors, I'm not necessarily going to control what my body does with those behaviors. And that's the single biggest barrier, because it affects every single level of how we approach this condition. It affects whether or not insurers are covering treatments. It covers whether or not health systems are investing in delivery systems to make sure that people can actually get timely care. It affects to what extent do we have the right tools and knowledge and skills at the bedside to help people who are presenting with concerns in this space, to be able to help them have the right information for their particular situation. And it's a very complex disease. So people's root causes are hugely heterogeneous. And so understanding what different people's root causes are and helping work with them around personalized plans for them that work in their life and health, means that we have to actually approach this condition in a really, really different way. But the underpinning fundamental issue is understanding that this is a chronic disease. And as a chronic disease, it means that there isn't, quotes, a cure, end quotes. It means it's a lifelong story where we have to be partners. And I love what Michael Vallis always says when he talks about, this isn't teach and tell, it's coach and collaborate. And it's lifelong coach and collaborate. It's not, oh yeah, we're just going to do this thing and we're going to be all better in 6 months or 12 months. No, it's like a lifelong story. And I'm sure Sandra can speak to that in her work. This is a long story. And, right now we have a situation where we don't have a workforce which is trained, that knows how to do that. So we've got quite a lot of work. So I think, Sandra, that's a long-winded answer to your question on barriers, but yeah.
No, but it's an important, I think that you're right, it is lifelong. And so how do we partner with our patients for the long term and collaborate with them to develop those long-term treatment plans. Over to you, Mega.
Yeah, I mean, again, when we talk about barriers and difficulty, that's probably the biggest challenges when things aren't going well, or again, internal bias and learned behavior, learned helplessness really dictates, you know, what's gonna make this time successful, or I've done this a million times before, you know, how do I actually achieve what I'm trying to achieve that's going to be different this time? And to your point, Denise, I think education is so important. There's nothing more sort of compelling to me for why I keep doing what I do, even though it's quite difficult to practice in this field. But when you see that patient sort of have that aha moment of, you know, I've been doing this, and the reason why I perhaps have been struggling is because I'm not really understanding the pathology of what's actually going on. You know, what are the hormones that are causing me to feel so hungry? Why is it that I crave at this time of day? Or what are some of the background history that has caused my brain and body to function in this way? Really having that understanding and that aha moment, I think, really helps patients to understand that this is not something that I necessarily have 100% control over. That's my biology. That's what's happening inside me as a disease and a pathology. You know, here are the tools that I'm going to use to reframe that, or here are the tools that are going to help me be able to overcome those challenges because now I understand what's happening. And the other thing from a motivation perspective is really moving away from sort of weight-based goals. And I think that understanding, you know, why am I doing this? What is going to make me get up every single morning and show up and be that person that I'm trying to be? What is that thing that's going to allow me to, you know, make those decisions consistently in the long term, even though my weight may be fluctuating or all these other aspects of my life may be dictating differently? You know, what is it inside me? What is my value system that's going to allow me to be more successful most of the time? And really helping patients to understand together what that value system is. To me, that's the thing that I am constantly going back to in the patient conversation to help with that long-term motivation.
Yeah, and I think that also offers hope. So sometimes when we talk about obesity management in the long term, it's sort of a bad news story, right? And someone like myself can become very discouraged at the idea that I'm just always going to be working against my body's defending its highest weight. And I, of course, never want to go back to my highest weight, but I need to know that I'm successful. And when I look to my values and when I'm honoring my values, then I'm successful every single day, which in itself becomes intrinsically motivating. So Denise, how do you keep your patients motivated?
Well, I think, you know, it's very interesting. I think one of the big difference between primary care and tertiary care for this is that you're with people for decades, right? And typically you'll have the whole family, right? So you may have the grandparents and the parents, and you may realize that some of the older generations are suffering with type 2 diabetes, or have different genetic risk factors that contribute to the experiences of some of the younger family members. And so, you know, it's always, in my view, chronic disease is always situated in a person's life and in their overall life world of all the other things that are going on them. So when people are going through COVID-19 and now we're having, you know, huge amounts of family violence, or we're having a lot of issues with mental health, we're having job losses, we're having people lose their homes. And then you factor chronic diseases like obesity into that mix. It's really about understanding where people are at and helping people be as healthy as they can, irrespective of what's happening in their life world. And then trying to help people mitigate risk. So, you know, someone who may have been very, very engaged with a program before and perhaps has stabilized their weight or is at a lower body weight, how do you help them then navigate tremendous family stressors and difficulties and stay weight stable during that, right? They may not have the snap in their elastic to really be able to engage in a really multidisciplinary program for a period of time while they're going through whatever circumstances they're going through. But the lovely thing about family medicine is that you're still there 6 months from now when they are ready to get back together with, perhaps a program or something a little bit more structured. So in that intervening time that they were dealing with, the illness of their parent or the illness of their children or the job loss or whatever else was going on, how do you help them stay stable and stay healthy? And then also, as you're looking at all of their health conditions, right? How do you help them when they're dealing with their migraine headaches to pick medications that are more appropriate, less obesogenic? How do you help them with managing some of the other issues, like now the urinary incontinence that's developed, now they don't want to go to the gym? Well, okay, let's deal with that urinary incontinence. So it's about situating all of that in everything else, right? So it's a longer term. It's not just about, quotes, being motivated to a plan as it relates to conventional obesity treatment. It's about how do you actually help people be healthy so that they're able to engage in all these good healthy behaviors irrespective of weight.
And it's such an unusual time with COVID-19 and the pandemic. So Mega, what have you noticed in your patient population? How has that impacted their weight management?
Yeah, it's kind of interesting. When everything sort of shut down here in Ontario, I was sort of red alarm, patients are going to have difficulties. I'm going to make sure that I'm trying to see them more often. I'm going to be really as hands-on as they would need in a situation like this where they may be struggling more. And it's interesting that what I found was a lot of the time when patients or when people removed some of their external drivers, like the commute to work or the socialization that they had to have in different environments, when they actually took that away, I found a lot of patients felt that they actually had more control over their day. They were actually able to schedule things in a way that they perhaps wanted to, and they didn't have all these external competing factors that they did in their previous, quote unquote life. But to that point, there was new factors that played a role. So, how do we really help switch that journey over to this new life that they're experiencing? And it almost allowed me to have the discussion with a clean slate, because as a endocrinologist, I would often see them after they have tried many different things, been to many different practitioners, and then landed on my doorstep. But this was the one opportunity I had to have a discussion with them right at the time where they were making change, and perhaps implement those goals and that value system right from the beginning. So, although there was definitely new challenges, and as Denise says, I really like the way you put that, Denise, because it really, from my perspective, it made me zoom out a little bit and look at the patient as a whole and all the different aspects that may be factors in their journey and what they're trying to achieve when it comes to obesity management, but actually helping them as a patient as a whole. And when it came to COVID-19, I found that discussion was very different than it was a week ago, a month ago, which is good for some patients and perhaps not good for some others.
So I have a final question for you both. Once your patient achieves significant weight loss, do you consider him or her to be cured? Denise, do you want to start?
It's an interesting question, and I have this debate sometimes with the diabetologists. If you have a patient who has type 2 diabetes, and I had one that lost over 100 pounds. They were one of the 5% of people that were actually physiologically able to do that with lifestyle modification, and normalized their blood glucose readings. And I had quite a debate with their endocrinologist when I wanted to take that off of their problem summary list, no more diabetes. And so, I think you could probably count angels on the head of a pin on that question quite a bit around, would the person have a tendency towards, ectopic deposition of, toxic adipose tissue in places we don't want? Yeah, probably. On the other hand, if they've normalized all their physiological markers, then, do they still have the condition? I think it gets into, Sandra, a little bit of, we would argue that a person who has a BMI of 24, who maybe comes from Southeast Asian background, who has a little spare tire around their middle, and who actually has type 2 diabetes or metabolic syndrome, actually has obesity. they have excess adipose tissue in the wrong places, which is toxic and causing metabolic harm. So, you know, again, it moves away from the number on the scale to the physiologic status of the patient, right? It's not about being a large human, it's about being a healthy human. So I don't think that quote success or quotes cure should be defined by a body size, right? So that's just sort of musings about it. And I think you could go both ways, but I think really what matters is, what does the person think, right? Are living their healthy best life? Are they able to do the things that they want to do? You know, as you shared, and I thought really eloquently, are they able to live their values and feel really good about who they are in the world and feel like they're able to do everything that they need to do in the world? Then that's great. That's a healthy human, and that's success.
Mega?
Yeah, and I would just add to that, you know, I think that I totally agree with everything that you just said. The one thing that comes to mind is, you know, when patients sort of say, well, you know, I've been seeing you for weight management and I'm doing really well and I feel really good. You know, when is the program over? And I think that that's really probably done the best job at explaining the chronic disease of obesity, because the challenge is not, it's not getting the weight down or improving things right at the beginning. It's the success of being able to maintain it and work on it consistently in the long term, because that's when our body's biology is the most active. It's when our body is trying to regain the weight and get back at the set point. That's the tougher part of the journey. And so if we let patients sort of go or be on their own at that time, I would say that that's sort of the highest risk time period that they would experience backlash or weight regain. So explaining that at the beginning, I think, is important. And it lends itself to sort of saying, you know, this isn't a cure. This is a support system to help you be successful forever, or give you an open air communication tool for when things aren't going well, and to anticipate that. And I think that those are the important discussions, and inherently what that lends itself to believe is that, you know, there isn't a cure, there isn't really an endpoint. This is an ongoing journey that we want to support you with long term.
Thank you. I understand Dr. Arya Sharma is on.
Yep, I'm here.
Great. Quiet in the background.
It's very interesting. I've been listening here for the last 5 to 6 minutes.
Wonderful. Did you want to ask any questions, or should we move over to the Q&A?
No, I think, you know, I can see that there's lots of questions coming in, so maybe we should start moving over to the Q&A.
Okay. Okay, so the floor is now open for your questions. We will prioritize live questions versus the chat box questions, and we encourage you to turn on your camera when you're ready to ask. Introduce yourself, let us know where you're tuning in from. So you have a couple of options. You can find your name in the participant bar and virtually raise your hand, or if you prefer, just raise your hand the old-fashioned way in your camera. And I'll just do a quick scan to see if anybody has their hand up. Yeah. Hey, Dale, is that how you say your name? Yes?
It's Smita?
Adil, yes.
Please tell us where you're tuning in from and ask your question.
Hi, my name is Adil. I'm the bariatric educator at Mavis Medics from Mississauga. So my question was, when you have older patients, it's usually hard for them to get into the lifestyle change. So I was wondering how your approach to older patients in terms of weight management.
Yes, so Denise, I think maybe we start with you there. I'm sure you've got a lot of older patients, elderly patients that you've been seeing for quite a while. When does this topic come? How do you deal with it?
Well, it's interesting. I mean, I'm thinking, as you said that question, I thought of 2 patients. And so I think where it comes up, so first of all, with patients who are older, like over 85, I actually find it very protective if they stay weight stable. So I wouldn't be super excited about them engaging in a significant weight loss story, even though some of them might like to, because having a little extra at that age group is potentially helpful. So when we think about the definition of impairing function, I'm thinking about a 68-year-old patient of mine who had very severe spinal stenosis, diabetes, chronic renal failure, depression, and was taking care of a spouse who was very impaired at the time. And this person was having a great deal of trouble ambulating, even with their mobility aids. And they were about 5'3" and 147 kilos at the time. And so, you know, we dealt with some of the root causes, right? So we had to deal with the depression piece, which was important. We got them into some compression stockings, which ironically for ARIA reversed their chronic renal failure because they were third spacing so much of their fluid, and dealt with a few of those issues. And then we ended up with this patient, because they were having so much pain with the spinal stenosis, we said, look, really the only option here is going to be pharmacology, because really they couldn't be very mobile. So we actually ended up going with Victoza because they had diabetes. They lost 30 kilos, it's down to 117 kilos, which is still a lot of body mass for the size of frame, but dramatic improvement in pain, right? And dramatic improvement in function due to the spinal stenosis. So I think in older patients, it's really driven by what is the thing that you're trying to achieve for the person's health and function. So we were able to achieve a much better level of function. And I just recently saw that patient in clinic. This was probably about, probably 4 years ago now. And so just saw them a week or so ago in clinic, and they were able to come into clinic without a mobility aid, right? Able to be out more with their friends and family, like even with COVID, over to the sister for dinner and stuff like that in their bubble. And you know, has done well with their depression. So on balance, you know, I think it really gets into what are the medical things and how is the weight impairing the health function in that group, if that's an effective answer. But I did recently have a 92-year-old who very much wanted to lose some weight. Not just because they wanted, you know, and again, you know, I'm very careful in that group. I would be, you know, trying to encourage them to be as active as they can and follow healthy habits, but I would be reticent about anything aggressive.
Great. So Sandra, back to you.
Yes, I understand we have a question from the chat box. So Rachel.
There is a question from Mary Jo, and the question is, can you comment on PTSD and obesity, as I find some of my patients who have been abused in childhood become the only obese members of their family, but even with therapy cannot lose weight?
So let me get this, you know, Megan, I'd like to hear you on this one, because you're an endocrinologist, and I'm assuming you don't have a background in psychiatry.
That's right.
So when you find a patient, you know, who's coming to you as, you know, you being the endocrinologist, and it takes you 3 minutes to find out, no, this is actually PTSD.
Yeah.
What do you do in that situation?
Yeah, and I think it's, first of all, thank you for asking the question, because it's something that as obesity medicine specialists, we actually do encounter more often than you may think that we do. And certainly in the bariatric surgery clinic, you know, I find that many patients have had a history of childhood abuse, or perhaps an underlying reason why they may be keeping their weight high. And so from my perspective, as you mentioned, Dr. Sharma, I'm not a psychiatrist, and I'm not going to sort of, you know, suggest that I'm going to be the one to treat this underlying condition, but I do think it is my job, and you know, for the patient's benefit to diagnose it or understand that this perhaps is one of the causes of your weight being at a higher weight and the difficulty with obesity, something we need to diagnose. So I think what I would say is, from my perspective, in my intake questionnaire, or the questionnaire that I have sort of assembled for the first interaction with the patient, it's important to ask these questions. And if there is something that is being unraveled there, it's important to ask the patient if they are open to speaking more about it, referring to somebody else in the community, perhaps a counselor or a psychiatrist. But if we don't ask the questions to start off with, we'll miss the entire sort of underlying cause. And I think that would be sort of a disservice if we're really thinking about treating this as the disease that it is.
So I'm hearing, don't be afraid to ask the question and make it part of your obesity assessment, right?
Right, exactly.
Okay, Sandra, back to you.
Yeah, I'm just scanning to see if there are any hands up. Yes, I see one. Samita, go ahead.
Mita's on mute.
Hi, sorry. Can you hear me now?
Yes, yes.
Perfect. So I'm Smita Desai Ranchard, and I'm a family physician here in Vancouver. So we're seeing, I see a fair number of obese patients in my office. And I have to say thank you to this amazing team, because for the first time last week, I actually reached out to a patient who's diabetic, had 3 episodes of Helicobacter, he's obese. And every time I approach the talk of lifestyle changes, it's, well, you know, it is what it is. And last week, I actually used the lines that was taught in this discussion.
Wow.
Your BMI qualifies you for medical treatment. And he looked at me and he goes, oh. And I said, let's understand how your brain works. And I talked to you about the homeostatic, the hedonic, and the executive pathway. And the man went, I'm so excited. I'd like to get involved. And so I have to say thank you. This was an amazing learning curve for me. Thank you. I just wanted to share that wonderful moment.
Thank you.
I'm going to take that as a question. I'm going to give it to Denise. Denise, when you have this kind of situation, you've got a patient, you've known them for a long time, they've been coming to your clinic, you've always wanted to talk to them about obesity, but somehow it never came up. How do you start that conversation in your setting?
Well,
Okay, Arya, given that we've been doing this together for 4 or 5 years, I don't have that many patients where I haven't actually asked the question now.
Remember the old days.
Yeah, but no, for sure. I think the biggest thing is just to ask people, you know, would it be okay if we discussed it? And people will say yes or no. And then the follow-up question is, can you tell me a little bit about your story? And I actually remember the very first patient that I did that with, which was one of our subsequent champions on the research. I said to this patient, who was about 63 at the time, coming in with bad knee OA, osteoarthritis. And before, I would have just said, oh, well, you know, if you lose 5 or 10 pounds, it's going to help your knee pain. And I wouldn't have thought much of it. But I asked permission and she said, sure. And I said, okay, tell me a little bit about your story with your weight. And she's like, oh, yeah, well, I've lost 110 pounds and I've kept it off for 8 years. I was like, oh, boy, am I glad that the first words out of my mouth weren't, oh, well, you know, if you just lose 5 or 10 pounds, it's going to really help your knees, right? So, you know, and then we got into a whole long story about, at another point, about sort of the story behind how that had all come to pass and what the story was for the person. I think the biggest thing I've learned is that everybody has a story. And the tools that we've created that are linked to in the guidelines through the algorithm, you can get to the 5A's team page and you can see the personalized assessment that comes out of people's stories for primary care. Everybody has a story. And the first thing is to really try to understand their story and have them understand their story and have everybody understand how it is that we came to be where we are. And the one thing I wanted to say about the PTSD is one of the nice things about being a family doctor is that hopefully you've seen those children when they were adolescents. And you can see them when they have been, you know, weight stable and now they're shooting up like this. Maybe if we're asking those questions earlier, we could intervene a whole lot earlier. One of the things I always tell my residents and students is every single one of our patients who is 350 pounds were 250 pounds and they were 180 pounds. And that took time. And where were we? Did anybody who knew this person, who had a therapeutic relationship with this person, ever ask them anywhere in that 150 pounds, would it be okay if we talked about your weight? Can you tell me a bit about what's going on? Did anybody ever try to understand and try to get that person treatment? Because I think if we got them appropriate trauma-focused counseling 150 pounds ago, we may have prevented a lot of hardship and suffering for that person. I had a chance to actually ask that question to one of the counselors on Aria's team, on the provincial bariatric team in Edmonton, who's a psychologist who treats a lot of patients, like what Mega was saying. And I said, Meg, how feasible would this be? What would that look like? And she said, about 40 hours of counseling. I said, really? So even if we said $200 an hour, that's $8,000. Could we not invest $8,000 in a young person at 21 years of age and prevent a lifetime of suffering and prevent all the downstream chronic disease and all the downstream challenges for that person? But what's not covered in our system mental health is not covered in our system. So if I have a young person who has disclosed that they have suffered those kinds of traumas, my options for therapy, effective trauma-focused care therapy for that person, if they're a person of limited means, is very, very, very limited, right? And so I actually asked the question, you know, should we not be investing 20 years earlier in the mental health piece for those patients and prevent the downstream problem?
Yeah. So Denise, you bring up this important point, and we've talked about before, is that like most chronic diseases, obesity also tends to be a progressive chronic disease. And rule number one in any chronic disease is rule number one: even if you can't do anything else, slow progression. I would say as a former nephrologist, because that's what I actually trained in. I mean, that's your goal. It's not to restore kidney function; it's to prevent deterioration of kidney function. If I can keep a patient from dialysis for another 5 years, that will have done my job. So I think that aspect of chronic disease management, where sometimes really the only achievable goal is to slow progression, and that's a very reasonable goal, and we've talked about this before. But the sooner you start, the better, right? That's what we have to remember here. Sandra, what else do we have?
Yes, we have some question from the chat box, so I'm going to hand it over to Rachel.
Question is from Elaine. The question is, I have a patient who is a great candidate for Contrave, but cannot afford it. Her drug plan will cover naltrexone and bupropion. Can a combo of these be used in lieu of Contrave? And if so, at what doses?
Okay, so that's a very interesting question. It's not a rare question because we get that question quite a bit. And you might actually have a similar question in patients who might already be on bupropion. And then often the question is, well, do I just add do I just add naltrexone, or do I start them on Contrave? So Megha, what's your take on that? I mean, do you get that question? How do you respond?
Absolutely, I get that question all the time. Certainly, initially, what I did try that combination. Of course, if a patient can't afford Contrave, I was really trying to do whatever I could to get them on treatment. Unfortunately, the doses are never going to be exact to the combination that's in Contrave. So Contrave is 4 tablets a day, and there's really no combination or dose specific of bupropion or naltrexone that will give you the exact dosing. There's also a difference in terms of the long-acting and short-acting forms. So what I found is clinically, unfortunately, the combination of bupropion and naltrexone outside of Contrave was not usually clinically effective for weight reduction in my patients. However, if we're thinking about symptoms of obesity when it comes to craving management and hunger, sometimes I did see a therapeutic effect by using the combination. So my approach is, it's very patient dependent, going back to personalized and individual treatment. In some patients, it's perhaps worth a try to try and get the doses to be as similar as possible. But just like any of the pharmacotherapy treatments, if you're not seeing clinical effectiveness, within 3 months of using that agent, I would say discontinue it. In my general practice, I tend not to, because I haven't really seen that therapeutic effect whenever I have tried it. But again, for symptom control, sometimes that could be where it could be effective.
Yeah, and it's also cumbersome, right? Because you don't have the added effect of giving, both medications in one. And as you said, it's a slow release form, so that has certain advantages. Back to you, Sandra.
Yes, we have a question from Stephen. So I'll ask you to unmute yourself, introduce yourself, and let us know where you're calling in from.
Hi everyone. My name is Stephen. I'm a family physician from Malaysia. My question is to Denise. And back to the topic of today is about treating obesity as a chronic disease. According to our family medicine theory, we use chronic care model. We want to ensure that patients living with obesity, they are empowered. But in our practice, especially in my region, whereby Asian are the majority, so empowered patients are rare. So for those not empowered patients, how do we manage in primary care? Do you have experience or research proving their efficacy in our treatment?
So Denise, that's a question for you. Self-efficacy. How do you get your patients to engage and actually feel that they can do it?
Yeah, well, so thanks, Stephen. It's actually, you were not a plant. This is actually an area that we've done a lot of research on. There, if you go to the Obesity Canada webpage, and maybe in the background, one of the colleagues from Obesity Canada could help pull it up. There's for the link, but there's if you just Google Obesity Canada and then 5AST, which is the 5A's team, you'll get to Aria's and my page. And on there, there's a blue button, which is download the toolkit, and it's free, but you just have to put your information in there, and you can see the videos and the personalized assessment that comes out of that research. And the reason why we published on this in public patient education and counseling, it's there's a couple of aspects of it which help us to build that self-efficacy. So it's around helping people believe that it is manageable, that they can manage, that they understand, and that they can manage, and that there's purpose in the action. So really Antonovsky's lipogenesis model. And one of the things that was transformative in the research was it starts with just generally their value-based goal and where they are with their life and health. The second part is them telling their story and listening. You're listening the whole time as the family doc for the root causes, and generally you have their profile, like you know if they have GERD or whatever the case is. You don't need to give them standardized questionnaires. You're listening. And then you go into the strengths and challenges. And so you frame, okay, so you have a lot of strengths. These are all the things that you've achieved in your life. These are all the different things that you've overcome. Your current challenges are whatever they may be. And you seek to make sure that you're understanding accurately. I have had so many patients in the research actually burst into tears because, first of all, they thought they were going to come into a consultation and be shamed and blamed. And secondly, they've said things in the interviews like, I didn't know I had any strengths, which is actually a devastating statement. When you frame it that way and you shift the thinking that way, people, there's something that happens. People become quite empowered to be able to think about an action plan, right? So it's a completely different encounter than what people would normally experience. And it seems to be very helpful in shifting people towards being able to be activated. So one of my teachers way back when I was training in family medicine, Chris Cates, he had given me a graphic which was change happens not just there's knowledge, but then there's belief in ability to be able to change. And in the last 25 years in family medicine, I've only ever had one patient where I said, you know, the 2 liters of full sugar Coke that you're drinking a day are contributing to your weight. Who said to me, really? Immediately stopped the full sugar Coke and lost 30 pounds. One patient. That was also the patient of mine who couldn't read and used to bring me all of her correspondence because I was the only person she knew who could read, right? Everybody else, it's not about the knowledge, it's about the belief in ability to be able to change, the belief that I could have a different story, right? So that whole body of research is around hearing their story and then helping them co-create a new story. Yeah. If that makes sense. So anyway, that's a long-winded answer. You weren't a plant, but yeah.
Yeah, and Denise, as as you know, this is also why in the weight bias chapter, we put such a huge emphasis on the issue of internalized weight bias, because patients are used to, I mean, part of their lack of self-efficacy comes from the fact that they're just blaming themselves. They believe what everybody's been telling them. And that, just overcoming that often, and you're right. I mean, these are very strong patients. I mean, the patients we've seen, if you listen to their stories, it's just amazing. So thanks, Stephen, for that question. Sandra, I think we have time for one last question, perhaps.
Great. Maria, please unmute yourself and ask your question.
Hi there. So I am a registered dietitian, and I work in private practice, and also I support a multidisciplinary team in obesity management. So I have an opportunity to work with a physician. My question is, like, as the registered dietitian, what role do you really see in helping patients with obesity in their treatment? Considering that people have to pay for sessions with me and with for the most part dietitians in Ontario, and going back to their value system, often it takes a lot of time, and if people are seeing me as a dietitian, they want results, and that means for them weight loss. So I don't have kind of time to, you know, go back to just looking at their value system, why they want to lose the weight. So I guess it's a little bit of a vague question, but where do you see dietitians being part of this treatment?
So Megan, why don't we start with you, because you're in Ontario, and what's the situation there? Well, what is your expectation? You're the specialist. If you have a patient and you're recommending they see a dietitian, what are you expecting the dietitian to actually do?
Yeah, so I think this is a fantastic conversation because it has come up so often with the new guidelines, given that we've really moved away from even the word diet and moved more towards sort of medical nutrition therapy. And so in my practice, that is what I tend to reserve specifically a dietitian for. So not for nutritional counseling, not for sort of, you know, patients come from, as Denise mentioned, all different walks of life. Many of them don't really come to me for dietary support. They have a good understanding of how they want to eat and what they enjoy eating, and they tend to eat well. So it's really the patients, for me, that are having difficulty with understanding food intolerances, or having to have a specific diet for a specific medical issue, or wanting to see a dietitian for specific dietary guidance. That's really who I reserve my RD designated dietitian for, because of, in Ontario, again, the cost associated with it. But everyone who's working in a weight management program should be able to help with the behavioral counseling piece, the values piece, the understanding piece. So that really shouldn't fall, you know, for example, on your shoulders. If you're trying to use every minute of your time to the patient's benefit, I would say that conversation should happen right from the beginning. And it should be every single healthcare practitioner that's involved in the patient's care. When it comes to the dietitian specifically, I would ask the patient what they want out of the discussion, because it's very interesting what comes out of it. It could be something very simple, or it could be something very complicated. And then perhaps use those answers to understand whether you're the best person to be providing that service, or maybe there's another practitioner that's involved in the clinic that you know, the patient has easier access to. But I tend to reserve my dietitian for specific patients that need specific dietary counseling that has to do with medical issues or something like that.
So it's all about appropriate referral, if I get you correctly. Denise, your setting is different. You have access to dietitians in the PCN.
Yeah, we do. And actually, so, and Robin Anderson, who's a registered dietitian here in Alberta, has been a partner every step of the way in all the work we've done. It's been a very interdisciplinary approach. And actually, the personalized assessment stuff of primary care, Robin was my partner in crime in that as well. So, because one of the things we learned was that if in our setting in primary care, if the family doc didn't feel comfortable talking to the patient and just said, "Oh, I'm worried about your weight, go see Robin." Well, there's been no lead up for that. There's been no value-based conversation. There's been no assessment, you know. And then what was happening is these patients would arrive on Robin's doorstep, and nobody had figured out that they did have PTSD or other things that were really important to address. So we set this up as a warm handoff that anybody on the team could initiate that, but ideally the family doctor would do it because there's more of us than the dietitians. And then again, it's a warm handoff. So if it's also, we developed a tool together, an interdisciplinary management tool, where there's key messages for the dietitian that if they identify, hey, this person is having trouble with urinary incontinence, patients don't expect to talk to their dietitian about urinary incontinence. So it's key messages about why that matters and how to do a warm handoff to the person on the team who can help with the urinary incontinence, which is preventing them from being active. So it's a little bit more of a team approach, but in our context, dietitians are still rare. Like, we only have 25 in our PCN, and we serve 250,000 patients, right? So therefore, you know, it's still a precious resource that we have to make sure, as Mega says, that they're the right port of call for that person, that person needs their help. But it's really a team sport. I think, in primary care. It's really a team sport, and it's helping the person just get to the right professional for the right information at the right time. But we asked patients, and what the patients told us, actually we did a qualitative study of a lot of patients. We asked them, what do you want from your primary care team? And what every single patient said was, I want a plan for me. I want something personalized for me, right? And so therefore, if they're taking your precious time, it should be because that was a personalized part of their plan, that they needed something, that you were the right professional for them, for what they needed. So it's more of an upfront marriage rather than sort of like well, let's just randomly be anybody and see if something sticks.
Yeah. So thanks so much for that perspective. Now I see Reno has raised his hand. Maybe we'll take one last, is it a question or a comment?
I think it's from the chat box. Rachel?
Oh, yeah, I see a raised hand.
Oh, you see a raised hand. Sorry, I was in a different view. Yes, let's go ahead. Unmute yourself.
Yeah, Reno, just go ahead.
Can everyone hear me?
Yes.
Yep.
I want to thank everyone for being here today, and I wore my beautiful red shirt for the opportunity.
Nice.
I heard some amazing answers to everyone's questions, and I do have a final question for tonight's, I guess, session. So a big part of our with regards to primary care and with the physician care, the medical care and the non-pharmacological care and the pharmacological care. So my question, I guess, is on a national level. A big part of where we're struggling is patients are having a hard time affording services, whether it be a dietitian, whether it be mental health, or whether it be physical fitness. Where are we today with regards to making strides so that the Canadian government can be able, I know that they're having a hard time recognizing obesity as a disease. I think the evidence-based literature out there is very, very strong and it's very compelling. But what can we do to fill in that gap?
So Reno, let me quickly try to answer the question, because first of all, I think one of the issues we have in Canada is that healthcare is actually provincial. So it's not about the federal government. We have to work this province by province, territory by territory. That's why you see that the standards of care are actually different from one province to the next. We've just heard about it. We've seen, we heard Mega talk about Ontario, and we heard Denise talk about Alberta. And if you talk to someone from BC, it's different again. So I think what we have the problem is, and this is really where Obesity Canada is working very hard with our patient advocates and obviously with all of you, is where we have to do the advocacy work to change the thinking around obesity and make it as as normal for someone to have a good medical care for their obesity as they have for any other chronic disease. So thanks very much for bringing that up. We don't have a lot of time left here. In fact, actually, we've just gone over the time. So Sandra, last words to you.
Yes. Yeah, before we close today's session, I invite you to consider what you will do differently tomorrow morning in your practice. When considering obesity as a chronic disease, this really opens the door to breaking down the stigma and bias that we may hold, and also the internalized bias that our patients may have. Will you consider that obesity looks different for different people, that it's not merely BMI, it's really about adipose tissue, fat, and where that is located on the body, and whether there are comorbidities. And lastly, a great conversation starter could be saying to your patient that your weight is in the range that qualifies you for a medical intervention. We've run out of time for today. If you want to continue the conversation, join Obesity Canada Connect Pro. And also you will receive a feedback form via email after today's session. Please take a few moments to fill that out. We want to know how to best serve you. Please remember to type in your full name in the chat box if you would like to receive the certificate of attendance after all 4 sessions are complete. And our final meeting of the series is this coming Thursday, November 5th at 11 a.m. Eastern Standard Time, where we will talk about how do we manage emotional eating and cravings. Thank you, and we'll see you next time.